So before you can understand diastolic dysfunction, you have to know about diastolic function. Okay? Um, the heart has a systolic function and it has a diastolic function. We did multiple lectures on systolic function. That's how well the heart is contracting, how well it comes in. Um, you know, I don't want to say pumping blood out because the diastolic function also uh, tell you how well blood is pumping out of the heart. But there's a systolic function when it contracts, and then there's a diastolic function when the heart fills. So the heart has to relax and fill with blood. So in a nutshell, that's what we mean by diastolic function. So to look at diastolic function, we are going to look at mitral inflow velocity. You've been exposed to this, the E and the A, but not only the E and the A, we're going to look at IVRT, which is isovolumic relaxation period or time. We're also going to look at mitral annular velocity, that is your E prime, A prime, and your S prime, that's mitral annular velocity. We're going to look at pulmonary vein flow, the systolic component, diastolic component, atrial reversal. We are also going to look at left atrial volume because left atrial volume is now a prominent feature in assessing diastolic uh, dysfunction. So we're going to go over the method to measure how you measure how you measure left atrial volume and the cutoff value for that. There's a new recommendation which is a tricuspid velocity. So we're going to go over that. The color M mode propagation, it's not there, so we're not going to stress on that. And then we're going to close with the grading of the diastolic dysfunction. There's only three grades now: grade 1, 2, and 3. So we're going to go over that. So the lecture, this lecture is very, very important to understand, to grasp the concept. I'm not sure if we can finish in 45 minutes or 60 minutes. What we're trying to do is not to rush through the lecture because you have to understand this fully. Um, all right. So let's look at a few things. All right. So let's go over when we say. I mean, remember the cardiac cycle is divided into a systolic component and a diastolic component. Okay. When we talk about diastole, that is when the heart essentially fills with blood because the heart has to pump blood out, but it first has to get filled up with blood. And so that is the diastolic period. Okay. If we further break it down and analyze it fully, diastole starts with what we call IVRT, and we've been over this before. Diastole starts with IVRT, which is isovolumic relaxation period or time. Okay, so just after the blood is pumped out of the heart and the aortic valve close, the mitral valve is also closed. The mitral valve is not yet open. So all the valves are closed. That is the beginning of diastole. That's the beginning of the diastolic period. Again, just after systole, when blood is pumped out of the left ventricle, we sort of just looking at the left ventricle. The same thing happens on the right side. Blood is pumped out of the left ventricle. the aortic valve close, but before the mitral valve opens, that period of time is what we call the isovolumic relaxation period or time. And that time varies from, probably from 150, so that time varies from about 60 to about 100 milliseconds. 60 to 100 milliseconds. Then the mitral valve opens. When the mitral valve opens, and we're talking about a young individual, when the mitral valve opens, there's like a suction of blood from the left atrium into the left ventricle, and that produce the so-called E velocity. So blood is flowing from the left atrium into the left ventricle. There's a pressure difference, so that's one of the reasons why the blood flows from the left atrium to the left ventricle. Then when you have an equalization of the pressure in the left atrium and the left ventricle, there's actually a cessation of blood flow, and we call that diastasis. That's diastasis. In some individual, diastasis may be non-existent. In some individual, especially if you have bradycardia, the diastasis may be a little prolonged. After diastasis, then you have atrial contraction. The atrium contracts to add a further amount of blood to the left ventricle. So those are the four components of diastolic function. Again, IVRT just after systole, when the aortic valve closed, the mitral valve is still closed. Then the mitral valve opens because there's a pressure difference. Then there is a suction of blood from the left atrium into the left ventricle, producing the E velocity. Then you have diastasis, equalization of pressure between the LV and the left atrium. Then the atrium contracts, giving rise to the A velocity. So that's the diastolic period. Of course, after the A velocity, then the mitral valve closes, but the aortic valve is still closed. You're now entering into systole. But when all the valves are closed, the muscle is building up energy to contract. That period of time when all the valves are closed is what we call the IVCT, isovolumic contraction time. So let me see if I can just draw it. Okay, you have to understand the diastolic period and what it constitutes. So if we were to draw it, all right, let's use this. So let's draw it. So if we're to draw it, you have your baseline. Oh my goodness, this thing is. All right, just assume that this is a straight line. All right, so when you have systole and blood flows out of the left ventricle into the aorta, you have your, this is, if you call this the left LVOT envelope, blood flowing through the left ventricular flow tract across the aortic valve into the aorta. You get something looking like this. On your Doppler, when all the valves are closed, there's no volume change. So we call that IVRT, And let me just exaggerate it a little bit. So this period of time right here is your IVRT. Let me change the color. So from there to there, that's the IVRT. Okay? All the valves are closed. The aortic valve is closed. The mitral valve has not yet opened. This period of time is or IV. Okay? Isovolumic relaxation period of time. Then the mitral valve opens right here. Blood is sucked into the left ventricle from the left atrium, mainly because there's a pressure difference, and this gives us the E velocity. So that is your E velocity. Okay? E velocity. In some individuals, you get a diastasis where there's an equalization of the pressure in the left ventricle and the left atrium. So there is no flow. See mainly in patients who are bradycardic, but in many individuals, you're not going to see it. Then after diastasis, the atrium contracts. Then the atrium contracts. And you get your A velocity. Okay? So IVRT, E velocity, diastasis, and your A velocity. These are the components of diastole. Okay? And it's important to understand these components fully. It's very important that you understand these components fully. So you can measure the IVRT, you can measure the peak E velocity, you can measure what we call the deceleration time. So the deceleration time is the time from the peak E to the baseline. So it's a time event. And you should learn how to measure these periods and intervals and times. Deceleration time. So it's from the peak E to the baseline, and the computer will give you the measurements. Also, you measure the A velocity, but not only you should measure the A velocity, you can measure the A duration. So when anything is any duration, this means it's a time event. So you're going to measure from the beginning of the A to the end of the A. That's the A duration. Okay. All right. So now that we fully understand what diastole is, then we can move on. All right. You also should know about the Wiggers diagram, and I'm going to go over this in a little detail. All right, so the Wiggers diagram basically combines all the waves and pressures and volumes that we have talked about, and you should know about the Wiggers diagram. Let's start with the ECG. So the ECG is right here, Of course, your ECG has a QRS complex. It has a T wave, it has a P wave, and a QRS, and then it repeats itself. So systole is from the beginning of the QRS to the end of the T wave, and then diastole is from the end of the T wave to the QRS. So those are things that we've been going over and over. When you look at the left ventricular volume, okay, so the amount of blood that's in the left ventricle, in systole, the blood is going to be pumped out of the left ventricle, okay? So the left ventricular volume is going to decrease in systole because blood has been pumped out. But in diastole, you start filling up the left ventricle with blood, and the left ventricular volume increase. So that's what this represents, okay, as left ventricular volume. And the volume of blood is going to vary with systole and diastole. In diastole, it's going to be the left ventricle is going to be fully filled with blood. And in systole, it's going to pump the blood out. Okay, so there's a fall in the volume in systole, there's an increase with diastole. The bright blue line represents the left ventricular pressure. Left ventricular pressure. In systole, when the left ventricle is contracting, it generates tremendous amount of pressure. So it moves from pressure close to zero all the way up to this what we call the systolic blood pressure. Then in diastole, the pressure falls because it's now relaxing and filling with blood. In systole, the pressure goes up again. Okay. The aortic, if you look at the aortic pressure is not going to fall to close to zero. Less, you'd pass out each time it falls to zero, and then, so it does not fall to zero. There's a higher, baseline pressure in the aorta. So you get a diastolic pressure. That's why you have, aortic diastolic pressure. So the lower pressure in the aorta is what we call the diastolic pressure. Then in systole, when the left ventricle pumps blood out into the aorta, you get a systolic pressure. Then when the left ventricle relaxes and you have diastole, you get a diastolic blood pressure. So that's what this is. So the top one is the aortic pressure. The bottom one is the LV pressure. And this lower one is the atrial pressure. So the atrial pressure is not going to vary tremendous. So you need to know the Wiggers diagram, know the different components, understand what they stand for, know how it works. All right, so this is what we just went over. When you look at the mitral inflow, that is the blood flowing from the left atrium, going into the left ventricle, crossing the mitral valve. That's why we call it mitral inflow. The IVRT, which is isovolumic relaxation time, is the period between when the aortic valve closes and the mitral valve is still closed. So all valves are closed. The reason why I call it isovolumic because the volume is not changing. Okay. E velocity is when the mitral valve opens and blood is sucked in from the left atrium into the left ventricle. This is the passive early filling of the left ventricle. And then we'll talk about the diastasis, which is the period between the early passive filling and the late active filling. This is, you don't see this prominent in a lot of patients, but it's there. And then the A velocity, which is the active late filling of the left ventricle due to atrial contraction. And so if this is the heart on the left side, mitral valve, your sample volume should be at the tip of the mitral leaflet, looking at blood flowing into the left ventricle. You get your IVRT. So first, This envelope is the flow across the left ventricular flow tract. Then when the aortic valve closes, the mitral valve is not yet open. The mitral valve is not yet open, so you have your IVRT. Mitral valve open, blood is sucked in from the left atrium to left ventricle. Okay, describing your E velocity. Deceleration time is from peak E to the baseline. It's the time. Then you have your diastasis, because there is equalization of pressure between the left atrium and left ventricle. There is no flow, and then the atrium contracts to force blood into the left ventricle. The mitral valve closed. The aortic valve is still closed. You have your IVCT, isovolumic contraction time, and then the process starts over. So in actuality, you get this. So this is what you get this. So this is your two-dimensional echo is on top. Your cursor is across the mitral valve. Sample volume is at the tip of the leaflet. Okay, so you have your E velocity and your A velocity. Your ECG is on top. Systole is from the beginning of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. You should know how to measure your deceleration time from peak E to the baseline. You can also measure your A velocity and your A duration. So you're going to come to the baseline, measure from the beginning of the E to the end of, the beginning of the A to the end of the A. That's A duration, okay? All right, so that's mitral inflow. So we now move to our mitral annular velocities. So when we talk about mitral annular velocities, it's the velocity at the mitral annulus. It's not the velocity at the septum. It's not the velocity in the left atrium. It's not the velocity in the left ventricular cavity. It's the annulus. So if you don't put your cursor on the annulus, the measurement is inaccurate. Okay, so this is obtained by placing the sample volume at the medial mitral annulus and the lateral mitral annulus. So the sample volume have to be placed at the annulus. You use P Doppler, pulse wave Doppler. So your two-dimensional echo is on top. Your cursor is placed at the annulus. Sample volume is at the mitral annulus. Annulus. If it's not placed at the annulus, your measurements are inaccurate. So when you press your P Doppler, so your mitral annular velocities are pulse wave Dopplers, but they measure velocity in centimeters per second, whereas when you do your mitral inflow, it's usually the order of meters per second, whereas the mitral annular velocities are usually centimeters per second. Much slower. So the tissue moves much slower than the blood. You're going to get what we call a S prime or a S wave. Okay? So once you press your annular velocity button or your P Doppler button, you're going to get a S wave, and then you get two diastolic waves. You get an E prime and an A prime. Remember, your ECG is always on top. Okay? Your cursor is right there. Okay? So if you just analyze what's happening in systole, remember the heart, the base of the heart moves up to the apex. So or sample volume is right here. So in systole, This base of the heart is going to move up towards the transducer. So you get from your basic Doppler principle, you're going to get a wave which is above the baseline. That's why this S prime is above the baseline, because the mitral annulus in systole moves up. Okay, it moves towards the apex. So it's a wave that's above the baseline. In diastole, the mitral annulus moves away from the transducer. It moves downwards. So you get these waves which are below the baseline. The first diastolic wave is your E prime. The second diastolic wave is the A prime. Okay, mitral annular velocity. Sample volume should be at the annulus, not in the septum. All right, so your S prime is your systolic annulus velocity. Systolic annulus velocity. The annulus moves upwards in systole. When we do cardiac mechanics, you're going to realize that, we've been talking about the pumping function of the heart. And, we sort of simplify it like the heart comes in, and the heart does much more than that. The heart twists, the base moves up to the apex, and the apex moves down a little bit. So, there's like a ringing motion of the heart in addition to the heart pumping, coming in. So anyway, so your E prime wave is the early diastolic annulus velocity, and your A prime wave is the late diastolic annulus velocity. A couple of things. E prime actually reflects relaxation of the myocardium. So E prime is very important. If there's muscle disease, your E prime is going to be affected, straight up. So muscle disease is going to be reflected in your E prime. E prime is reduced in patients with impaired myocardial relaxation. And if the patient has a problem with compliance, it's also going to affect E prime. So a decrease in E prime is one of the earliest markers of diastolic dysfunction. So if the patient have diastolic dysfunction, it's going to affect E prime. So the patient cannot present with diastolic dysfunction and a normal E prime. It doesn't exist. All right, so another thing, E prime ratio above 15 suggests elevated pulmonary capillary wedge pressure. So this is where we start having updates, because this is only true for the medial annulus. Remember, we do the medial annulus and the lateral annulus. So we do measurements at both. So if your EE prime at the medial annulus is greater than 15, it suggests elevated left ventricular filling pressures, increased pressures in the left ventricle and the left atrium. There's also a new concept of average E prime. And the average E prime, you're going to take the E, the medial E and the lateral E, you add them together, you divide them by 2. That gives you the average E prime. So you're going to see that concept, average E prime. You can also use the lateral. So if you're going to use the lateral, then your EE prime ratio greater than 13 is the number you need to remember. So for medial EE prime ratio, if it's greater than 15, it suggests elevated filling pressures. for average, if you're going to use the average E prime, so the EE prime greater than 14. If you're going to use a lateral, then it's 13. And okay, if the EE prime ratio is low, and I think the current concept is if it's less than 10, then it suggests that you have normal left ventricle end diastolic. The pressures are normal once it's less than 10. The pressures are normal. All right, so we're going to go over that because those things are very important. But then we look at the pulmonary vein flows. What is pulmonary vein flow? Well, you know that the pulmonary veins, once they get fully oxygenated, once the blood is fully oxygenated, then it flows. The blood is going to move from the lungs into the pulmonary veins, and the pulmonary veins going to drain into the left atrium. Okay, so if you have your two-dimensional echo on top, your left atrium is right here, left ventricle is right there. Okay, we can actually see two pulmonary veins in this view, in the apical four-chamber view. You have a right and a left, and these are superior pulmonary veins. So if you put your sample volume in one of the pulmonary veins, for a normal individual, so your ECG is on top here, you get a systolic component, and you get a diastolic component, and an atrial reversal. Okay, atrial reversal, which is right there. Okay, so if you're normal, then in systole, so we're talking about ventricular systole. In ventricular systole, blood is flowing from the pulmonary veins into the left atrium. In ventricular diastole, blood is still flowing from the pulmonary veins into the left atrium. But when the atrium contracts, blood is going to flow in the opposite direction. Remember this again, this is your transducer right here. If blood is flowing from the pulmonary veins into the left atrium, it's flowing towards the transducer, so you're going to get an envelope above the baseline. So in systole and diastole, blood flows from the pulmonary veins into the left atrium, okay, above the baseline. But in a normal individual, the systolic component is greater than the diastolic component. But when the atrium contracts, it's going to force blood in the opposite direction, away from the transducer. So your atrial flow reversal is below the baseline, okay? So systolic component, diastolic component, atrial reversal, atrial flow reversal. This is what your normal pulmonary vein flow looks like. If you have elevated left atrial pressure, then your systolic component is going to get progressively lower. Okay? So someone with higher grade of diastolic dysfunction, the systolic component of the pulmonary vein flow is going to get progressively smaller once you have elevated left atrial pressure. So you'll have what we call diastolic predominance. All right, so you have your systolic component, systolic wave. You have your diastolic wave, and then your atrial flow reversal. As the left atrial pressure increases, then the systolic component gets smaller and smaller. Diastolic dysfunction is fairly common. Our diastolic heart failure is common. You know, it's important to understand diastolic dysfunction, because when we talk about diastolic heart failure, which is really the current term is heart failure with preserved ejection fraction, it accounts for about 50%, half of all patients who are presenting with heart failure. So you have to understand diastolic function and diastolic dysfunction, because its prevalence is tremendous and it increases with age. Okay. So when you grade diastolic dysfunction, the higher the grade, the higher the left atrial pressure, the higher the left ventricular filling pressures. Okay. So we're gonna discuss some current concept right now. So when we can look at diastolic dysfunction. All right, before we go to that, let me develop the concept of left atrial volume, because that's another important uh, concept, left atrial volume. So if you have, so when we talk about diastolic dysfunction, there's something wrong with the left ventricular muscle, something wrong with the muscle. So the muscle is not either relaxing properly so that the heart can fill properly with blood, or there's a problem with compliance. The heart is just not filling. So, if you want to get real basic, then the heart muscle is probably stiff. So the heart muscle is stiff. So that's going to generate an increased pressure into the atrium. So once you have significant diastolic dysfunction, the atria are going to get larger. The atrium going to get bigger, because the left ventricle is not relaxing. It's sort of stiff. It's not filling properly with blood. So that pressure is going to generate all the way back into the left atrium. So if the patient has significant diastolic dysfunction, the atria gonna be big. The atrium is gonna get enlarged. That's basic. So you have to understand that concept. And that is why left atrial volume is an integral part of grading diastolic dysfunction. And we measure left atrial volume. The current method to measure left atrial volume, you measure, it's a what we call an area length method. You take your two-chamber view and you trace the borders, and it's not any willy-nilly tracing. You have to trace it properly. Okay, you trace the borders and then you do the what we call the length. So the area, when you trace the borders, you get the area, and then from the mitral annulus to the top of the atrium, you get the length. You're going to do that in your 4 and 2 chamber view. Okay, that is done in the 4 and 2 chamber view. The area and the length. What you do, you multiply the area in the 2 times the area in the 4. You're going to divide it by the shortest length, because you measure the length in the 2 and the 4. And you multiply that by 0.85, and that will give you left atrial volume. If you trace it and you plug in the values, the computer give it to you. But you have to know what the computer is doing. Okay? You have to know what the computer is doing. So let me just explain that a little bit more, because understanding that concept is very, very important. Okay? So again, it's not any willy-nilly measurement. You have to measure it properly. So let's all right, let me use this as my drawing board. All right, so you're gonna have your 4 chamber. Let me see if I can pull this off. right, so you have to just assume that this is a normal heart. Okay. All right, so assume this is a normal heart. All right, so what you do, you trace the left atrial border. This is a 4-chamber view. Okay, so you're going to trace the border. And this is exactly how you don't want to do it. It's supposed to be inside the left atrium. Okay? So it has to be, don't, I say a lot of people, because they know they're supposed to do it, they just do any little old thing and that's it. No, it has to, try and do it properly. So you trace the border, left atrial border, and then you do the length from the annulus straight down. This is the length. So you do, it's the area and the length, 4-chamber view. And then you do your 2-chamber view, so your 4-chamber view. Okay, so you're going to trace the border. So the area in the left atrium, and then you do the length. Okay, from the mitral annulus down to the top of the atrium. So you're actually going to get, if you call this area, call the area here A1. And call this length L1. And then call this area A2. And call this length L2. So the left atrial volume because you might confuse. The left atrial volume is equal to A1 times A2 divided by the shortest length. So you're going to measure this length here, you're going to measure this one, and whichever is the shortest, that's the one you're going to put. Right away you see that the area times the area is going to be a dimension to the 4th power. And then you divide it by a dimension, so you get a dimension to the 3rd power. So that's a volume. and then you're going to multiply this by 0.85. The computer will do that for you. So this is a point right here. So once you do your tracing and you plug in the values, the computer will do this part for you. But what the computer is doing is taking the area in the 4, multiply times the area in the 2, and dividing by the shortest length, and multiply that by 0.85. The cutoff value that you need to memorize is 34, and it's an index. Again, it's left atrial volume index. So when you index anything, you get that value and you divide it by the body surface area. So whatever volume you get here, you divide it by the body surface area, and that's what you're going to use. Left atrial volume index. And the cutoff value is 34. If your left atrial volume index is greater than 34, it suggests that the left atrium is enlarged, and that suggests elevated filling pressures. So this concept, you have to understand this, and those of you who do echoes, you need to start reporting left atrial volume. Okay. The other thing that you need to also do is your tricuspid regurgitation velocity, your TR velocity. You have to measure that. TR velocity, tricuspid regurgitation velocity. And the cutoff value for that is 2.8 meters per second. Okay? All right, let's get rid of these. All right, so when you talk about diastolic dysfunction in someone with a normal left ventricular ejection fraction, one of the concepts you need to fully embrace is that if the patient have LV systolic dysfunction, if the patient have reduced LV systolic function, they already have diastolic dysfunction. So all you have to do is grade it. However, if the patient have a normal ejection fraction, you have to take age into account. The age of the individual is important, because as one gets older, there appears the LV gets stiffer. Okay? As one age, the LV gets stiffer. And if you just follow the mitral inflow for a number of years in an individual, you'll see that the E velocity gradually gets lesser and lesser and lesser. The reason for that is because the LV gets stiff, and the atrium now have to take over a larger role in filling the left ventricle. So that is why the A velocity becomes more prominent. The A velocity increase because the LV gets stiffer, so the atrium have to now work a little bit harder to pump blood into the LV, so that the E velocity gets smaller and the A velocity gets larger. So in LT sedentary elderly, diastolic dysfunction appeared to be in part due to increased LV stiffness. The indices that are less age dependent, because you want to use something that is less age dependent, is the E prime. Okay? E prime in a normal individual is rarely greater than 14. Okay? So if you're a normal person and your E to E prime is greater than 14, it's unlikely, because the E to E prime, so this is an E prime, E to E prime greater than 14 suggests that there's problem with the muscle. Okay. Also, um, indices that are less age dependent is changes in the mitral inflow velocity with Valsalva maneuver. Valsalva maneuver is when you strain. Okay, so you take you take a deep breath against a closed glottis. That's the medical description. But it's basically, if you strain or bear down, that is the Valsalva maneuver. And the Valsalva maneuver have 4 phases, but basically the basic thing you need to understand is that when you do the Valsalva maneuver, you're reducing the amount of blood going to the heart. You'll decrease venous return to the heart. So when you do the Valsalva maneuver, the changes that you're going to get is less age dependent. Important thing that we also use is difference in duration between the pulmonary vein atrial reversal velocity and the mitral A velocity duration. So what we're saying is that if you measure the duration of the atrial flow reversal in the pulmonary vein and the atrial flow reversal in the mitral inflow, those differences are less age dependent. So these are things that don't vary a lot with age. So we use them periodically to help us to assess diastolic dysfunction. We have, so these are some basic concepts. I think we should stop here, because now we're going to go into the meat of the matter, so to speak, and it's going to take probably another 40 minutes. So I think let's stop here, get the basic concept straight, make sure you understand the basic concept,